everyone, and welcome in nursing webinar. Myself Shanti, the Vice President Nursing, and we will be discussing about the urology specialty in this month. Today, let us see who is our very eminent expert panelist. Is none other the very incredible persona who we have today is Dr. Srinivas Garu, who is our senior urologist and transplant surgeon, urologist and clinical director for urology department. His clinical skills are very highly appreciable. I welcome you, sir, and thank you for your valuable presence. Despite of your very busy surgery day, you have contributed for us. Thank you so much.
Thank you.
And let us also welcome our the senior nurse lead, who is Miss Swati, always charming, and she's very able, sincere, and very dedicated. I welcome you, Swati.
Thank you, ma'am.
And by not very wasting time, let us see the prevalence as we are going to talk about the renal transplant pre and post-operative care, and let us look at the prevalence. And one of the, as everybody knows now, the awareness is very high in the society that this is one of the very leading causes of mortality worldwide, and it is one of the non-communicable diseases in type and increasing since the past 2 decades. And as we would like to hear from sir also, why this, as we able to accurately measure the prevalence of this condition, sir. Sir, we would like to know your. Yes.
So, renal failure, that is end-stage renal disease,
Yes,
is a highly prevalent disease in our country. And now there are so many factors which are contributing to the renal failure. The first and foremost being diabetes mellitus, and next is the hypertension, and later on comes the other disorders. And most importantly, one not to forget about the misuse of NSAIDs, which is leading to significant amount of renal failure. In India, every year there are about 2 lakh new people requiring entering ESRD and requiring renal replacement therapy, either in the form of dialysis or in the form of renal transplant, but only because of the paucity of the donors. So only 1/10 or even less than that are able to get a donor for a renal transplant.
So let us also see what we have in today's session. Over to you, Swati, for the rest of the session. Yes.
As we discussed today, renal transplantation. The transplantation is a surgical implantation of a kidney from a compatible donor to a recipient.
So here we would like to also understand from sir that what we should understand by donor incompatibility, as we have nursing learners as students as well.
So whenever you're doing a transplant, that we have to make sure that the blood group of these individuals are the same. But this particular thing has changed now. So earlier we were doing only renal transplant across the same blood groups. So now with the advancement in the technologies, we are able to do renal transplants even in individuals having different blood groups. Now it is called as ABO incompatible transplant. Any individual of different blood group, if he is donating to the recipient, and this recipient prior to the surgery undergoes certain sessions like plasmapheresis, or there are certain special filters where the antibodies to the donor's blood group are removed prior to the surgery, and thereby again we can facilitate a renal transplant, and it has become quite popular and very successful.
Then coming to the risk factor and causes of the end stage of renal disorder. Mostly there are several causes are there, but the main causes are diabetes mellitus, type 1 and type 2 diabetes mellitus, and uncontrollable hypertension and polycystic kidney disorders.
So, sir, these are the causes of, as you were mentioning, as end stage is the very common factor. And if we talk about polycystic kidney disease, they also require transplant, I think, within some duration of time.
So now coming to the causative factors, as I have already mentioned to you that diabetes mellitus is one of the most important causative factor in over 30 to 40% of the patients. And the second most important is uncontrolled hypertension. And coming to adult polycystic kidney disease that we also called as ADPKD, it is a congenital disease. And so this particular disease is not that rampant, but once in a while you do come across these patients. So it is not such a significant cause when compared to this. But again, this is a preventable one. So when someone in the family is running and having this particular gene for having a ADPKD, so we can screen the family and we can try and prevent further progression of this particular gene into the future generations. So, and most importantly, the other important factors are infections of the kidney, be it a general infection leading to kidney failure, or it can be a tuberculosis which can lead to kidney failure, and NSAID induced. Painkillers are vastly used in our country. Across the counter, you get all the painkillers, and everybody is very fond of taking these painkillers for every silly thing. And this is leading to significant causes of kidney failure.
Then types of transplantation. There are three types of transplantation. One is disease donor transplantation, live transplantation, and as sir told, ABO incompatibility. In the disease donor, when no living donor is available, disease donor transplantation offers hope to those waiting for a kidney. Then live transplantation, a life-saving process where the kidney donated by the voluntary donor and behalf of all the procedure. ABO incompatibility, when the donor between and the recipient incompatible, that is known as ABO incompatibility.
So as you have already mentioned, this is a new trend of operating on the patients, and this group of ABO incompatibilities, do they have to wait longer than deceased and living donor?
So now, most important factor that all of us have to remember is that in India, over 5 lakh road traffic accidents are happening. And if you can, all of them are a potential renal donors or organ donors. If we judiciously and consciously convert most of them as the disease donors, so by creating awareness among the public, so much of the burden of this renal transplant from the living donors or ABO incompatible will come down. The burden on the dialysis machines will come down. But the thing is, unfortunately, still the awareness is not that high. Fortunately, at least in Telangana, people are more aware and more disease donor transplants are happening. But this awareness has to spread across the country, and we should be making every possible individual voluntary disease donor. They should carry the donor card in any of eventualities that organs can be retrieved and used. And that will definitely reduce the burden. And coming to the living donor transplant, because of the nuclear families and diabetes being quite rampant and already other comorbid factors are there, they are preventing from the family members donating to the needed family, whoever is the patient in the family. And ABO incompatible transplant that has come to the rescue, because in the present situation of nuclear families, when somebody in the family wants to donate, but the thing is their blood group is completely different. Now, at least with the techniques and the technology of ABO incompatible, we are able to at least address to some extent some of these problems.
So thank you so much, sir, for the very beautiful and the updated information which we didn't know, but today we have just, because of your insight, we have come to know. Yes.
Thank you.
Coming to the investigation part, where the nurses are playing very vital role to sending the information, investigation, and collect the reports on time. If any abnormalities will be there, we are just notify the physician as soon as possible. For here, donor and recipient, the common investigation are the surgical profile, which we are sending from pre-admission, and the main investigation, which is for recipient, flow cross-match and human leukocyte antigen, which is cell and tissue cross-match. And the for donor specific investigation are DTP renal scanning and HLA-Evidia.
So, Swati, since you have been mentored by Srinivas sir and his team, so here can we also know whether what is the DTPA scan? What is the rationale behind to do this DTPA scan?
Yes,
Let-
ma'am.
yeah.
In the scanning, where we can know the glomerular filtration rate, which is can identify the donor kidney, which is the coming for voluntary donor, it was working properly or not. The normal GFR rate is the 120 ml per minute.
So, sir, I think is this rational right? And if GFR is not okay, I mean, it is not meeting the criteria. So, those group also wait for the kidney transplant, or do they go for the dialysis or some activity, or your advice?
Can you just come back with your question?
Sir,
This is
as we said, GFR is a criteria for the TPS
correct,
scan, and
correct.
if this the donor whose GFR is not meeting the expectation,
Right.
they have to wait for the dialysis or some other clinical intervention we tell them to take. Yes.
So now Swati has mentioned that the GFR should be 120, but the thing is, textbook wise, an ideal GFR, though not for an Indian patient, it is 120 ml per minute is the ideal thing. But the thing is, most of our donors, whether it is a donor or not donor, when we routinely see in our clinical scenario in Indian situation, Indian population, usually the GFR is around 80, 90. Anybody whose GFR is more than 80 is accepted as a donor. So there is absolutely no harm in accepting anybody having 80 plus. Suppose somebody's GFR is grossly falling below the range, then definitely we need to discourage that particular person from donating, and we can look for another donor in the family.
Yes, sir. Thank you.
Then the very essential period is the pre-op management. A part of all the pre-op management, here I'm going to just point out some points which is need to be cross-checked double times. About anticoagulants, if patient are having any heparin and clopidogrel and aspirin, we need to stop that medication 1 week prior. And anyhow, we know all the protocol NBM and ball preparation. A part of that will reserve all the things. And immunosuppressant and antibiotic spray, very vital role. We need to give in antibiotic magnesport 1 hour prior to the surgery, and immunosuppressant tacrolimus mycophenolatisis according to the nephro orders. Then soon after receiving, we receive the patient in the post-op area. After receiving the patient, we need to check all the intra-op, how much fluid we given to the patient and what is the output. A part of that, we need to check vitals, monitor IVC and renal Doppler, which is very essential here. A part of that, we need to check electrolytes, patient on the NBM till 6 hours, then we can start clear liquids. Soon after receiving post-management, pain management is very important, but we can't give fentanyl on floor means frequently. Fentanyl may cause constipation for some time for the patient, so we are keeping fentanyl patches. A part of that, we just manage the pain injection paracetamol TID doses. For the DVT prophylaxis, we are using crepe bandage for the lower limbs. Then antibiotic and immunosuppression depends upon the order. Then 48 hours, the second POD, which is we are doing frequent ambulation, and we can regularly checking the creatinine level. As we see in the screen, the IV fluid management here, if the patient output is coming 500, then we are giving the equal.
Swati, just a minute. Here we would like to also take sir's guidance on whether, just go to the previous, yes, this slide. So these are by default, we have to follow these orders. Do you also, you or your team face any kind of challenges when you go for rounds or you give the instructions, or any sensitization you would like to convey to the nursing group here?
Yeah. So the most important aspect of immediate post-transplant patient is that care of IV fluids, whatever the patient is putting out. Sometimes the patient puts out as high as 1 liter per hour. So it is mandatory that we replace that. Otherwise, we'll be in deep trouble. For that reason, everybody should have an eye on the fluid that is going in and also on the output that they are having. You cannot afford to miss out on this particular thing. And at the same time, when we are looking at the urine output, the first thing, if there is no urine output, somebody has to make sure that the catheter is not blocked. The first thing the nurse who is there at bedside should be putting her hand on the suprapubic region, that is in the lowermost part of the abdomen, to look if there is any bladder distension. This bladder distension can be disastrous because you have just put the new ureter onto the bladder and new anastomosis has been done. If somebody, a small clot has come and has blocked the catheter and you are not noticed it, so then the entire anastomosis is going to for a rupture. So the patient has to be taken into the theater again. So this is very, very important. Whenever there is no urine output, just not think about that. Okay, there is no urine output, then inform doctor. No, first thing, put your hand on the abdomen and see that there is no bladder distension. Make sure there is no retention of urine. That is most important from surgical point of view. And the second important thing is we always keep a drain for these patients, and it is very important. Not only you're looking at the vitals, the most important is you have to have an eye in the first at least initial hours. What is the drain output? Suppose suddenly there is some blood vessel which has given away and the patient is bleeding, and your drain you have kept in some corner and you have not kept your eye at all on that, you're only looking at the intake and output, then you'll be again in trouble. So please make sure that you are frequently looking at how much is the drain every hour or every 15 minutes. And at the same time, the vital monitoring is also important, because sometimes the BP shoot up very high. At that time, you should be taking an immediate action so that the BP should be kept at a normal level. Otherwise, they can disrupt the blood vessels which have been recently anastomosed. And also the very low BPs are also not very, very good for the patient, because any new vascular anastomosis go for a thrombosis if you don't address the blood pressure problem immediately. So very high BP is also problematic, very low BP is also problematic, excessive drain is problematic, urine not coming is also problematic. You have to have a very close monitoring on this particular thing. And as far as DVT prophylaxis is concerned, so some units for the recipients, they avoid it, but at least when you avoid it, you have to make sure the patient is moving the limbs properly, and also you have TED stockings there in place and properly placed. So these are very, very vital, and definitely, yes, we should not allow any patient to suffer with pain. The pain has to be managed appropriately.
So I'm sure, Swati, I was just writing down few new points which sir has clearly mentioned, and I would like to send to you as well. You can just display and take the training and awareness session for your nurses and the learners who all are viewing this webinar, for you all to just take this point and manage the patient, because we cannot compromise the patient safety post-operatively. Yes, we can talk about the role of IV fluids.
As sir told about all the fluid criteria, we are here mentioned one fluid chart. So you can see if the patient output is equal, then we are giving to equal amount. A part of that, we can see the chart and we can give the fluid. Then coming to the 72 hours, it is the third POD, frequent emulation, as we told before, we need to be mandatory. And graft function, if the creatinine will be normal, that is well and good. If creatinine will be elevated day by day, then there is the chances of any delay function of the graft. Then a part of that, ISO balance is very important in this phase.
So yeah, ISO balance. So can we hear from you what training do you give to your nurses or your juniors? What is about this ISO balance? And
yes, ma'am. Here we are following till third POD, post of the third to till discharge. We are maintaining ISO. ISO means is equal to the output. If the patient output is 300 ml the last hour, the next hour we are just replacing the same amount of fluid, which is known as isobalance, and we are just going through on that process also.
So, sir, would you also validate that she is right? Yes.
Yes. So fluid management is, as I said earlier, also it is very, very important, and these people are very, very sensitive to fluids also. So we need to keep in mind not to push too much of fluid and not to under push the fluid. So the correct amount of fluid replacement is vital for a good outcome. So if you suppose err and start giving more IV fluids and the output is less, then suddenly these people can go into pulmonary edema and you can have a serious problem there. So, and if you are not giving adequate amount of fluids, so the kidney can go into acute tubular necrosis. So it is very, 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 very important and valid point that your fluid intake and output should be very closely monitored and planned accordingly. According to the output, your intake has to be planned.
Yes, sir. One more valid thing which I would like to ask is what the observation which nurses are supposed to do for the graft function. do they have to, report to you for any objective signs towards the graft area? Because, yeah.
No. So coming to the wound area, as I have mentioned earlier, we have only two problems there. When a urine catheter is blocked,
Yes.
or when the drain output is more. So these are the two times when as a surgeon I'll be worried about. So sometimes even when the drain output is not adequate or not coming much there, a patient, despite giving all the painkillers, suddenly complains of severe unbearable pain. Please have a look at the wound site. If there is any bulge, always urine or blood outside their system, they are highly irritant and they cause severe pain. And if you find a significant bulge in the renal transplanted area, first and foremost, whenever a patient comes, patient is covered all over with sheets and all that. A nurse who takes charge of a patient should make sure, remove the cover, examine how the wound and abdomen is there, so that next time when the patient complains, you can just have a look, then you know the difference. How was the wound earlier and how is the wound now? So these are very, very important to prevent any major catastrophes or disasters.
Then coming to the high risk medication. Here we are giving Solmetrol, which is we are giving in the operation theater 1 gram. And first POD we are giving 500 mg and followed by second POD 250 mg. Apart of that, in the third POD onwards, we are giving tablet Omnicortil 60 mg per hour per day. It is depends upon the patient body weight. Then coming to the immunosuppressant, when the patient creatinine is stuck in the point, otherwise it is elevated day by day, then we are going through the biopsy, which is discussed with the transplant team. In the biopsy report, if any graft function delayed or any AKI rejection will be notified, then they are going through the anti-rejection drug, which is thymoglobin and Simlac. Then
So
nutrition.
these are all high risk drug, which is nothing but HAM, high alert medications it falls under. And I think everybody should cross check before they administer to the patient, because immunosuppressants and steroids are very, very high risk in nature. I think everybody should develop a cross check policy before they administer.
And the point I want to make here is that whoever is taking care of the patient and administering these important drugs have to make sure that the IV line is properly secured and the IV line is patent, and there is no extravasation of the drug that is happening. And if you lose that drug, if there is extravasation, the adequate amount of drug may not reach, the blood level concentration may not be adequate, and it can lead to rejection. So there is a reason, make sure and always remember that whenever a vital important drug which is given to protect the kidney from rejection, make sure that you have given the injection and you immediately make note of it that you have given the drug. So otherwise what will happen is overdosage can happen, or sometimes underdosage can happen. And if your IV lines are not good and there is extravasation, then adequate amount of drug may not reach the kidney, so that all can lead to a kidney failure.
Yes.
Then coming to the part of renal diet, nutrition supplement is very important in the CKD patient. The stage 1 and stage 2, we just need to control the BP, blood pressure and diabetics. So we need to control about that. Then stage 3 and stage 4 patient might be in the dialysis stage. So fluid restriction need be mandatory. Then potassium need to be take less consumption and salt a part of that. Then renal transplant, post-renal transplantation, high protein diet mandatory. If the patient is the diabetic, then diabetic soft diet, diabetic normal diet, and we have to encourage the patient to take 4 to 5 liters of oral liquid.
So, here they again come back to your OPD for any sort of any diet related problem, or again maybe they must have not followed, or they must have contracted foodball illness. So do they also come back again for your opinion?
No, the most important thing for all these transplant patients who are on immunosuppression, our suggestion to them is try to avoid taking food from any outside joints like hotels or any other place. If there is no other option and you are forced to eat outside, the first and foremost thing is do not touch anything which is cold, anything which is refrigerated. you have to eat anything which is hot. So this I typically tell my patients that not to have any of those cold stuffs in the hotel, and exactly like a salad, try to avoid it. Chutneys, try to avoid them. If there is a hot sambar available, have it. Anything which is hot, steamed idli is available, sort of a thing, you can have it. If nothing is available, you're not sure about the hygiene of the hotel, what you're eating, then you can just go for some biscuits or some fruits which are available, washed them thoroughly, and you can eat. That is safer than eating any of these joints. And also whatever water also, not to drink water from here and there. At home you can drink whatever water you want, but the thing is when you're outside, preferably take water which is bottled. So, and the diet, as far as is concerned, is a balanced diet is very, very important. Again, people should not be going back to their old habits of eating everything and anything, so which can have a negative effect. And their diabetes should be kept under proper control. So, diet is the most important thing for protecting the kidney. And you have got a kidney, you need to protect that kidney, and you need to make sure that that kidney works for you for as long as possible.
Normal complication for post-op surgery, it is maybe, but potential complication are rejection, which may be graft rejection, function infection, bacterial or fungal infection, which we are giving pre-medication, and steroid-related complication, hypertension or diabetic, then drug toxicity, which is induced by tacrolimus level.
So yeah, you can go through the preventive and discharge advice.
Preventive and discharge step. Here we are having a very beautiful paper which is designed by our transplant team. Lifestyle habit need to be managed properly. Then food pattern, should not take counter medication. Then painkiller, NS, AIDS group should be avoided as sir told before. Then herbal medication need to be avoided for the patient. While discharge, we are educating the patient how to take immunosuppressant drug, how to take nutritional diet, and how much water they need to be consumption. Then we are just educate to the patient also how frequent they need to come for OPD basis and which reports. A part of that, we just give the handout paper which can be mentioned very clearly what they need to be do post transplantation and they should have avoid.
So we have come to the discussion. We have come to the end as a part of conclusion that it is a comprehensive care and continuous monitoring is required post transplantation. Here at Yashoda, we always provide a lot of awareness for the organ the organ donation. And here, sir, you would like to give any sort of message to the community, like on the
Yes, every one of us has to understand a point that so at the end of the day, health is the most important thing. So first, all of us should make sure that what we are eating is right and what we are following is right. Every individual needs a regular exercise, a good amount of sleep, and a healthy diet. These things will take you to a longer way and keep you away from the diseases. That is the most important. Suppose, unfortunately, we fall into a category of end-stage renal disease, then at that particular point of time, yes, definitely you need to have a right treatment, and the best treatment for any patient with an end-stage disease is a renal transplant, because you can be as nearer to normal life as possible after a transplant, and you are completely independent. You're not dependent on any dialysis machine. But saying all that, but the thing is, it's not that easy to get an organ like a kidney. It's not that easy. That is the reason the emphasis is that we all as a society has to move forward, understand the plight of these patients, and all of us have to voluntarily join this organ donation scheme or program. Our government of Telangana has got a beautiful Jeevan Dan organ program helping so many individuals. Each individual can save the life of 10 more individuals. So when we die, we don't take the organs anywhere with us. So it all goes into the dust. So I request all the people that you have to make a very conscious decision. Helping others is the best thing that we can do in our life, at least posthumously. Definitely, we can donate our organs to the society and at least make some other person live full life and a happy life. So my sincere request to everyone is become an organ donor. The organ donor cards are available and you can become a member. And if you carry the card, in any of eventualities, your organs can be potentially utilized by so many people who are waiting for an organ, be it a kidney, liver, lung, so the pancreas. There's so many other organs, eyes especially, and these are the many organs that can be utilized in a given individual.
So let us all pledge together to donate the organ and provide life and productive, to the society. Yes, and thank you so much, sir.
Thank you.
Cannot measure. I myself I was jotting down few points, and as if I am a bedside nurse, I am taking down your instruction for your beautiful, productive information to all the nursing learners out there. And thank you so much. And
Thank you very much.
Thank you, sir. And thank you, sir.
Thanks for the opportunity.
Thank you, sir. Thank you, Swati, for your beautiful presentation. I'm sure that you will be also teaching to your junior nurses for whatever, take-out message sir has provided. And we end the discussion here, and thank you so much, sir. Thanks, everyone.